Hello dear student. Today in this lecture we will discuss the amebiasis, which is an intestinal disease. After watching this lecture you will be able to learn about entamoeba histolytica that causes amoebic dysentery and liver abscesses, important properties, the life cycle of entamoeba histolytica, pathogenesis and epidemiology, clinical finding, laboratory diagnosis, treatment and prevention. So let us start the life cycle of entamoeba histolytica, which causes the important disease amebiasis. The life cycle has two stages: the motile amoeba, which is known as trophozoite, and the non-motile is called cyst. Now the trophozoite is found with the intestinal and extra-intestinal lesion and the diarrheal stools. The cyst predominant in the non-diarrheal stool. These cysts are not highly resistant and are readily killed by boiling, but not by chlorination of water supply. They are removed by the filtration of water. Look at the figure. This is the cyst, and you should note that the cyst of amoeba contain four nuclei, while the trophozoite is one nucleus. So the trophozoite is actually, they are found in the intestine and diarrheal stools, while the cyst is resistant to the environmental condition and they are found in the non-diarrheal stools. They are highly resistant. You should take care about drinking the water and the food. Now we have discussed that the cyst has four nuclei, which is an important diagnostic criteria. Now what happened upon excitation in the intestinal tract? Amoeba with four nuclei emerges and then divide to form a trophozoite. You acquired this organism by contaminated food and water. Suppose this is your contaminated food and this food has four nuclei and this is cyst. When you ingest this cyst during fecal oral route, now this cyst, what they do when they enter the intestinal tract, now the excitation occur and actually this form trophozoite. In the intestine they form the trophozoites. Now the mature trophozoite has single nucleus. This is the single nucleus of the trophozoite, and with an even lining of peripheral chromatin and prominent central nucleolus, that is chromosome. Now antibodies are formed against the trophozoites, antigens, and invasive amebiasis, but they are not protective. Previous infection does not prevent reinfections. The antibodies are useful, however epidemiological diagnosis occur. Now we talk about the pathogenesis and epidemiology. Now the organism is acquired by ingestion of cyst. This water or this is apple. If this water or apple contain the cyst, they are acquired through the ingestion. So the mode of transmission is fecal oral route by eating the contaminated food and drinking contaminated water. Anal oral transmission among male homosexual are also occur. There is no animal reservoir. The ingested cyst, when you take this ingested cyst, actually they differentiate in trophozoite in which part? In the ileum part, the last part of the small intestine. And actually they colonize the cecum and colon. You know that cecum is the part of the large intestine and colon is also the part of the large intestine. So the trophozoite ingested and they differentiate into the The cyst ingested and they differentiate into the tropozoites in the small intestine, but actually they colonize the large intestine. In which part of the large intestine? The cecum and colon. Colon is the largest part of the large intestine. Now the tropozoid, what the tropozoid will? The tropozoid actually they invade the colonic epithelium and secrete enzyme that cause localized necrosis. This is localized necrosis. Now little inflammation occur at the site. As the lesion reaches the muscularis layer, a typical flask shape. This is a typical flask shape ulcer form that can determine and destroy the large area of the intestinal epithelium. So they actually they form flask shape ulcer in the large intestine, and here they cause the intestinal epithelium destruction. Now progression, what after they attack on the large intestine, progression into the submucosa leads to invasion of the portal circulation by the tropozoid. Now due to the portal circulation, what they do actually by most frequent site of systemic disease is the liver. They goes to the liver where abscesses containing tropozoid form. Now the infections by Amebiasis histolytica is found worldwide but occurs most frequent in the tropical area, especially with poor sanitation. You know that it is a waterborne disease. Poor sanitations increase the risk of the amoebic dysentery. About 1 to 2% of the people in the United States are affected. Infection is common in men who have sex with men. Now, clinical finding. The clinical finding is acute intestinal amebiasis that present is a dysentery, mean blood mucus containing the area, and also accompanied by lower abdominal discomfort, flatulence, and tenesmus. Now, chronic amebiasis with low-grade symptoms such as occasional diarrhea, weight loss, and fatigue also occur. Roughly 90% of these infected have asymptomatic infections, but they may be carriers whose feces contain cysts that can be transmitted to others. And some patients, granulomatous lesion called in ameboma may form in the cecal or rectosigmoid area of the colon. These lesions can resemble an adenocarcinoma of the colon and must be distinguished from them. Amoebic abscesses of the liver is characterized by right upper quadrant pain, weight loss, fever, and tender in large liver. Right lobe abscesses can penetrate the diaphragm and can cause lung disease. Most of the amoebic liver abscesses occur in patients who have not had overt intestinal amebiasis. Aspiration of the liver abscesses yield brownish yellow pus with the appearance and consistency of the fast. Amoebic abscesses of the liver is characterized by right upper quadrant pain, weight loss, fever, and tender enlarged. Right lobe abscesses can penetrate the diaphragm. Now, laboratory diagnosis. Diagnosis of the intestinal amebiasis rests on finding either tropozoid in diarrheal stool, tropozoids in the diarrheal stool, and actually diarrheal stool should be examined within hour of the collection to see the amoeboid motility of the tropozoid. Now the tropozoids characteristically contain ingested red blood cell. This is tropozoid. This one is the nucleus and the other is the ingested RBC. Most common errors is to mistake fecal leukocyte for tropozoids. Because cysts are passed intermittently, at least 3 specimens should be examined. The ONP test is insensitive and insensitive and false negative commonly occur. About half of the patients with extraintestinal amebiasis have negative stool examination. This is the cyst, it contains the poor nuclei, and this is the tropozoid. This is ingested RBC, and the other is nucleus. Ant amoeba histolytica can be distinguished from other amoebas by two major criteria. First is the nature of the nucleus of tropozoid. Ant amoeba histolytica nucleus has small central nucleolus and fine chromatin granule along the border of the nuclear membrane. I have shown in the previous slide. The nuclei of the other amoeba are quite different. The second is cyst size and number of its nuclei. Mature cysts of Ant amoeba histolytica are smaller than those of Ant amoeba coli and contain 4 nuclei, whereas E. coli cysts have 8 nuclei. The most common error is to mistaken pickle leukocyte for tropozoid cysts are passed intermittently. Next. Now the tropozoid of Ant amoeba disper, a non-pathogenic species of amoeba, are morphologically indistinguishable from those of Ant amoeba histolytica. Therefore, a person who is tropozoid in the stool is only treated if the symptom warrant it. Two tests are specific for Ant amoeba histolytica in the stool. One detects the Ant amoeba histolytica antigen, and the other detects the nucleic acid of an organism by PCR. Complete examination for cysts include wheat mount in saline and iodine stain, wheat mount and apex trichrome stain preparation, each of which bring out different aspects of cyst morphology. These preparations are also helpful in the distinguish amoebic from bacillary dysentery, and the latter many inflammatory cells such as polymorphonuclear leukocytes are seen, where in the amoebic dysentery they are not. Serological testing is useful for the diagnosis of invasive amebiasis. The indirect hemagglutination test is usually positive in patients with invasive disease, but frequently negative in asymptomatic individuals who are passing cyst. Treatment. Treatment is actually metronidazole. The trade name is flagyl or tenidazole. Hepatic abscesses need not to be drained. Asymptomatic cyst caries should be treated with iodoquinol or pyromomycin. Prevention to avoid fecal contamination of food and water. Purification of municipal water. Now the use of night soil, human feces for fertilization of crops should be prohibited. In area of endemic infection, vegetables should be cooked.